Hello, this slide presentation will discuss drugs for headaches. Headaches are a common symptom and they are triggered by a variety of stimuli. It can be stress, fatigue, acute illness, sensitivity to alcohol, and hopefully it's not from a serious organic cause such as a tumor. Mild episodes can usually be relieved with over-the-counter medications such as acetaminophen, NSAIDs, aspirin. Severe headaches, such as cluster, migraines, or tension type, will require different medications. Some underlying causes can include severe hypertension, hyperthyroidism, a tumor, infection, disorders of the eye, nose, sinuses, and throat. But there's no identifiable causes for migraines or cluster headaches. We know what physiologically happens, but why it happens, we're not for sure on that. What's the overview of treatment for headaches? Drugs are used in two ways: to abort an ongoing attack. So then your aspirin-like drugs, your opioid analgesics, and your migraine-specific drugs can do that. And then for prevention of an attack from occurring, we're usually looking at the beta blockers, your tricyclics, and your anti-epileptic drugs. So first we're going to look at migraines. It's usually a throbbing head pain of moderate to severe intensity. It can be accompanied with nausea, vomiting, sensitivity to light, and they can be highly debilitating. Sometimes people are in bed for a day to 2 to 3 days. Some people have them almost every day out of the month or half of the month. That doesn't allow them to work or care for their families. There can be a hormonal component. Some women can see that when it's before their periods, they can get a migraine. Family history is typical, so they tend to run in families. There's two primary forms. There are migraines with aura, where they're preceded by visual symptoms, and then migraines without aura, which are actually more common. So how do we treat? We want to abort an oncoming attack or attack that's just started. We want to use analgesics, such as aspirin or opiate analgesics. And the thing with the opiate analgesics, we try not to use those all the time because they don't need the sedation part, they just need the pain relief part. That's what you need for migraine. People sleep so that when they wake up, hopefully the migraine's gone. It doesn't do anything to help the migraine go away. Migraine specific drugs we can use are those serotonin 1B, 1D receptor agonists, like your Imitrex or your ergotamine products. And then we can also try to prevent attacks from occurring. So those serotonin 1B, 1D receptor agonists, the one you've probably heard of would be Imitrex, sumatriptan. It works by binding with receptors on the intracranial blood vessels and causes vasoconstriction and diminishes inflammation, the perivasal inflammation, because with migraines you have constriction and dilation. They help to abort an ongoing migraine attack or when they first start, because we do know that the best way, the most effective way, when you first start to feel your aura come on, or the first part of pain, whether starts with some pain in your neck or tightening of your neck, that is the best time to take your medication and for it to be most effective. What happens is people wait until they ignore that and think, oh, maybe it's not going to happen. Wait till it's full blown, then try and take their medication and get very little relief from that. And they usually then just have to go to bed and go to a dark room and wait it out. So the therapeutic use for these meds is to abort as it's coming on. And you have oral preparations as well as intranasal preparations that patients are able to use at home. Adverse effects, you can get some transit. Heavy arms or chest pressure is usually experienced by 50% of users, but that is transient and goes away. You can have coronary vasospasm, which is a rare angina that can occur. They are teratogenic, so you cannot use them in pregnancy. Other side effects can be vertigo, malaise, fatigue, tingling sensations, or a bad taste in your mouth when you do the intranasal. Reactions, you can't take the ergotamine products with it, or other triptans because it'll cause too much vasoconstriction. And again, this oral or nasal preparations. And here are some of the other common preparations for the 1B, 1D receptor agonists that you'll hear from your patients when you ask what did they take. The other preparation that is besides the triptans, you have the ergotamine products, and those also work on specific 1B and 1D receptors. It is second line for stopping an ongoing migraine, but there is risk of dependence with this drug. You can have a toxicity called ergotism, and then the drug interactions, the drug dependence, and the contraindications. Other abortive agents for migraines. So then now we're discussing the preventive therapy. You have your beta blockers, your anti-epileptic drugs that are listed, your tricyclic antidepressants such as Elavil, estrogens and triptans if they are menstrual associated migraines. Also, calcium channel blockers can be used. Botulism toxin A can be used and can be effective. Your ACE inhibitors and ARBs can be used. Supplements such as B2 and CoQ10. And butter burr, which is a herbal preparation, can also be helpful. On to cluster headaches. These occur in a series or cluster attacks. They can last from 15 minutes to 2 hours. There can be severe throbbing, and it's usually unilateral near the eye. There's tearing, redness, nasal congestion, rhinorrhea, meiosis on the same side as the headache. They usually have 1 or 2 attacks a month, and then they can have attack-free periods for months or even years. Men are usually more prone also to cluster headaches. Treatment is directed at prophylaxis. The glucocorticoids, such as prednisone and dexamethasone, can be helpful. Verapamil, calcium channel blocker, and lithium. Last, your tension type headaches. Characteristics, they're the most common type of headache. They're moderate, non-throbbing. It feels like it's a band around the head. So the patient says they have this tightness around their head, think tension headache. If they say they have this severe pain in the back of their head, you see, or over their eyes, you probably want to think of, across the head in the front migraine. If they have the aura, especially if they have an aura before they have a tightening in their neck, or they see flashes of light, or scotoma, which is kind of the squigglies. That's what actually I have. Just the visual migraines. I don't oculars. I don't have a lot of pain. Or if they have it just on one side with the tearing and they nasal congestion, and thicker cluster. These tension headaches can be episodic or chronic, especially when the patient's under a lot of stress and anxiety. They can have a lot of tension headaches. For these, you want to use non-opiate analgesics such as acetaminophen. You can use your NSAIDs or aspirin. Um, you can do a combination with aspirin and the butalbital. So and then you can, a lot of patient teaching about stress. You may want to send them to stress management, or maybe even some therapy might be helpful to work on the issues that they're having in their life. Now onto the questions. Patients caring for a migraine headache, which would indicate that Imitrex is exerting the desired effect. The answer will be C. The patient reports termination of the migraine after the drug is administered. Question 2. The patient is prescribed ergotamine for a migraine, which statement means the patient needs more teaching. And the answer here is C, because we talked about the fact that you can develop some dependence to this drug. And the last question, the physician or practitioner prescribes propranolol for the patient with a migraine. It is most important for the nurse to do what? And the answer is D. Instruct the patient that the medication will prevent. So, of course, beta blockers are used in the prevention, not in the treatment once the migraine has started. And that is it for this lecture. Thank you very much.